did the sleep, characterize sleep and the different kind of sleep and things like that. So kind of pretty interesting there. So after 6 months of age, our sleep is classified into rapid eye movement sleep and non-rapid eye movement sleep. And we kind of cycle between these two. And it seems that we have different functions in each of these sleep patterns. In the non-rapid eye movement sleep, a lot of things are going on. Our energy is getting conserved. We are having a lot of important hormones being released in the body that are important for growth and nutrition. A lot of other blood supply to the muscle is increased. So a lot of things going on. In the rapid eye movement sleep phases when we're kind of dreaming and our brains are a little bit more active. So after 6 months, we're all doing there. Now, a lot of us snore, and not all snoring is bad. There is a thing called primary snoring, which is quite common and prevalent in about 3 to 12%. And it's really, it seems that this general benign snoring is actually quite benign, doesn't have any, possibly no clinical significance to that, and there's nothing more, the consequences of primary snoring has not been established. It's supposed to be pretty benign, and there is a small population of us who do that. The worrisome part is when there is obstructive sleep apnea, and obstructive sleep apnea is when we are sleeping and having trouble with breathing, such that we actually stop breathing at times, and that actually results in more significant consequences, such as we're not doing good gas exchange. So we're going to be breathing in oxygen, giving out carbon dioxide, but when we have sleep apnea, that seems to affect that, and we're not able to do that very effectively. There is another term called obstructive hyperventilation, when we are again having a certain amount of decrease in our ability to breathe correctly during sleep, and so we are retaining a lot of our carbon dioxide. So those are the two things that are actually more worrisome in sleep. And so now we know that, please let me know if I'm going fast. I just like to run through the slides very quickly. So sleep is actually a problem that we see not only in adults, but actually it starts from a newborn. In children, we see it mostly at 2 to 5 years of age, because that's the time when we see that the tonsils and adenoids are really big. So that is one period in time where it's noted the most. In children, males and females are equally affected, but as you get older, it seems the males are more affected. And certainly if there is obesity, that seems to be as a risk factor. So one of the causes that can cause sleep apnea, the commonest causes would be some kind of obstruction in your nose or in your airway. And in terms of cystic fibrosis, we see a lot of nasal polyps that seem to be causing that. And there's also a lot of chronic rhinosinusitis, some kind of upper airway inflammation constantly going on in children with cystic fibrosis that seems to predispose them to this. Also, other things with cystic fibrosis in particular is that they have a lot of cough in the day as well as at night, and this seems to disrupt their sleep. Also, they might tend to have decreased oxygen saturations in the day, and that might be seen at night, just a decrease in oxygen saturations. They are usually prone to having a lot of pulmonary flare-ups, so during these flare-ups is when we might see that their sleep is disturbed a lot with the cough as well as the decrease in oxygen saturations. And because of their lung disease in general, they might just be at an increase. They might just be breathing more harder, working harder to breathe. That can affect sleep. And then there are a lot of medicines that children with cystic fibrosis use which can affect sleep, such as albuterol. Albuterol is supposed is noted to affect their sleep, is that they can't fall asleep so quickly. Their ability to fall asleep is more prolonged. So a lot of things that can affect children with cystic fibrosis in particular. So how do we screen them? Screening is basically with, as with every other illness, with a history. So the things that we would usually ask you is, have you noticed any snoring in your child? Does your child pause or gasp while sleeping? Is your child very restless? Do you notice any grinding of his teeth? Any sweating? Any nighttime accidents? And kind of just feeling tired even though the child has slept for a very long time. So that might tell us that the quality of the sleep is not as good as we expect them to be, even if they slept for about 8 to 10, 12 hours. Also, if you notice constant open mouth breathing, or what we describe as adenoidal facies, where they kind of always have their mouth open, that is also gives us a hint that maybe they have prominent adenoids at the back of their tonsils. And sometimes they might speak with a nasal voice. Physical exam is mostly normal. There's nothing very noticeable except if there are polyps or vague tonsils and adenoids or anything like that. The pulse oximetry, when we measure oxygen saturations, can be absolutely normal. And so usually the way to diagnose sleep apnea is by a sleep study, which is done in a very accredited lab with experienced staff. Lab findings are, again, not very specific, but if there's been ongoing sleep problems for a long time, we might see a slight rise in the hemoglobin count, which just tells us that the body is compensating for all the work that they're doing, and so the hemoglobin is a little raised. Sometimes if we get a blood gas, we might see changes of, the fact that we're not doing good gas exchange while you were sleeping, and your body had to retain all that carbon dioxide and had to compensate. You can get some reflection of that on the blood gas. If sleep apnea is very severe, on the severe extreme end, and we can see changes in your heart and in the size of your heart, whether it's enlargement of the right side of the heart and things like that. Sometimes getting an X-ray of your neck, we can see those big adenoids that we might look out for. This is a picture of a fuzzy picture of a child who's getting ready for a sleep study. We see some electrodes on his head, and it's usually done at the sleep lab. It's no needles, just a lot of monitoring, basically. Just a couple of things, though. It seems that sleep apnea is not always related with big tonsils and adenoids. So we do have to keep in mind that even though the tonsil and adenoid size are smaller, you might still have sleep problems. It doesn't necessarily mean that if you're snoring very loudly, more chances of having sleep apnea. Sometimes you can even have sleep apnea if you have a child who doesn't snore or gasps too much. Sometimes sleep apnea occurs in the early morning hours when everybody is asleep. So that might be a time when parents might miss the opportunity to actually notice a child who's having sleep apneas. And like I said, sometimes if you're just not a loud snorer, then there's chances that we will think that's multi-primary snoring versus sleep apnea. So what is the treatment? The treatment of choice actually for children is surgical. That is, removing the tonsils and adenoids seems to be the most effective treatment. Sometimes we do have to monitor them for residual sleep apnea even after removing the tonsils and adenoids to see if there is something still going on. There are some medical therapies, such as we can use like nose sprays, which might help decrease the size of the boggy turbinates at the side of the polyps, and we can use some decongestants, but these are all pretty short-term. If sleep apnea does not resolve with surgery, the other option sometimes is based on your sleep study, and if it was a pretty significant sleep apnea, then we would do CPAP, which does help people with cystic fibrosis as well. Now, so it seems that it's very important to have an index of suspicion for sleep, because if we don't diagnose it, there are some clinical consequences, and we know that disrupted sleep can cause a lot of things. So it's not not just getting a good night's sleep, but it can also impact all the functions that we were supposed to do while sleeping. So it can impact hormones. Hormones which regulate our growth, such that we know it has been established that in non-cystic fibrosis children, sleep apnea can actually cause decreased growth and weight and cause failure to thrive. So all these things can affect sleep. It has also been noticed now that children with sleep apnea can have problems with behavior. So ADHD and all these different things have been associated with undiagnosed sleep apnea. Now, cystic fibrosis being a chronic illness, it seems that it also affects the sleep of families and parents, because since you're providing care in the day as well as at night, families of children with cystic fibrosis are also prone to a lot of increased nighttime awakenings and poor sleep quality, and it seems that there is an associated with elevated levels of depression as well as fatigue in family members. So just something to watch out for. So there's growing evidence of literature in the cystic fibrosis world with sleep. a couple of ones that were published that I chose was the first one, which was published in December 2012, looked at from ages, I do believe, I forgot to bring my papers here, but 40 children, I think they were more elementary school, and they compared it to 20 children. The 40 children with cystic fibrosis, they called them stable CF, meaning their lung function test FEV1s were in the 75% and above. Out of those 40 children, 10 of them had Pseudomonas, 10 of them had some sinusitis. And in the daytime, the 40 children with cystic fibrosis and the 20 normal children all had normal oxygen saturations of 98%. But when they did a sleep study, they found that the children with cystic fibrosis had actually evidence of sleep apnea on their sleep study test and were prone to having more nighttime desaturations. There was another study published, this was I think done in Italy, the one where it looked at infants. They took very young babies, 3 months to 36 months, and they took, I think 20 of those and 10 normal, and out of those 20 babies with cystic fibrosis, 7 of them had like a little runny nose and a cold going on at that time. They had a sore throat and a little kind of a runny nose, and all of them had normal chest x-rays. And they found out that the babies who were sick at the time of the sleep study had significant nighttime oxygen desaturations during sleep. So they just thought that, well, it seems that even very young babies are actually prone to having sleep problems when they're sick, and it's not only in older kids. The last one, they looked at adults with cystic fibrosis, and their lung functions were more severe, and they found out that adults with cystic fibrosis had an increased tendency of having sleep apnea, increased nighttime desaturations, and actually significant sleep apnea, so which affected their neurocognitive ability and thinking and things like that. So it seems that in the entire gamut, in the entire range of age group, children with cystic fibrosis and adults do tend to have a slightly more risk of having sleep apnea. So basically, I think this new thing now should just alert us to be a little bit more suspicious and to monitor sleep in children as well as in yourselves if you had increased sleep problems. And this is a sleep, the National Sleep Foundation put up this on how many hours you need as a child all the way to adulthood, and it looks like the younger you are, obviously you need more sleep hours, 14 to 17 hours for up to 3 months, and in the toddler years it's 11 to 14 hours, the preschoolers are 10 to 13. But once you get older, teens need 8 to 10, and then young adults need about 7 to 8 hours of sleep. And the wise man once said, the amount of sleep required by the average person is 5 minutes more. The sleeping beauty at least. Do you have any questions? Concerns?
You said on the lack of correlation between sleep apnea and tonsil and adenoid size. That's not saying that it wasn't necessarily causing it, but sometimes you can take out small tonsils and adenoids and still get better. Is that
Well, it seems that, not in the sense of take it out, but it seems that we usually, I guess you would most likely suspect sleep apnea if the tonsils and adenoids were pretty big, and we say, well, this seems like a most likely candidate because he has big tonsils and adenoids. But it seems that some children with even small tonsils can have sleep apnea.
And in that group, can the tonsils and adenoids sometimes be responsible for it, or does that just mean they have a different cause?
There could be many causes, but I'm not exactly sure whether removing them would be a good thing. I guess then the sleep study would rather be more objective to identify the severity and whether surgery is indicated or not, I guess in that case. Thank you.
I'm just curious, I'm sorry if I missed this, but does Sacred Heart provide sleep studies?
Oh, we actually have a new provider called Dr. Rainey, who is a neurologist and a sleep doctor, sleep specialist. And his clinic is at Holy Family, and he does do pediatric sleep studies. Before we were studying here at UCLA. But now we do have one here.
Thank you.
Okay, so now we are going to, this is a good time if you didn't get dessert, there's some yummy ones back there. We're just going to end our time with a little panel discussion. So I'm going to have, let's see, Lloyd and Abby. So Lloyd is our token person with cystic fibrosis here today, because we can only have one, and we're going to have one, it's going to be Lloyd. So Lloyd is an adult, I won't give ages or anything, but he's a wonderful patient, but he's also been great for our community, and we've had him speak before, but a great example. And so if you have toddlers, you can look to him as like what they will be someday. Great man, great family man, great patient, but he has a wealth of information. Then he's got his better half is a nurse, Abby, but she also works with cystic fibrosis patients, so we have kind of a power couple here. So I'll have them come up. I'd like Rebecca to come back up, and then also Sandy come back up. And then we have our providers here. They don't have to necessarily come up, but yeah, maybe grab a chair so everyone has one. But we're just going to kind of have a somewhat informal panel discussion, and I've got some more microphones. Some topics that were brought up in the survey that we sent out and with our parent advisory panel was medical terminology, that maybe there's things that are being said in clinic or questions that are being asked that maybe are not totally understood by either caregivers, parents, or even the patients, because sometimes we're asking, we start asking, around 10, 11, try to be a lot more focused, and even a 19-year-old may not really understand what exercise tolerance means. And so just kind of talk about that, and also just get their perspective on medical terminology, how it's used, maybe clarify. The other topic that was brought up was exercise. We know it's the buzz in CF is to talk about exercise, but what does exercise mean for a patient with CF? Does it mean they don't do any? Does it mean they run marathons? Is there somewhere in between? And so we have some great information on that too. And so what we're hoping this will be is kind of a round table in a room to talk about this. So I'll get the microphone ready, but think about what you want to say about like medical jargon. And then I'll have a mic if anyone doesn't feel like they can yell enough up there. So who wants to start?
First? All right. I will tell you my age. I'll be 40 in May. Unlike most people that are crossing 40, I'm actually super excited for it. When my wife tells me she notices gray hair in my beard, I'm like, that's a big deal. I'll take it. As far as medical jargon goes, well, I have a little bit of a cheat because my wife is a nurse, right? So when I hear big long names of things and stuff like that, sometimes I'll think about asking the clinic what's going on, but more I come home and talk to my wife because it's helpful. I think what I would say when it comes to medical jargon is don't feel like there is such thing as a stupid question, because we have to deal with so many things. And so even sometimes you can forget what bacteria your kid has in their lungs, and that doesn't mean you're not a good caregiver. It just means that you're a parent with a lot of things going on. And it's okay to ask and ask again, and even if it's stuff that you think you may know, don't hesitate to ask the questions and say, can you explain that to me in really simple terms? We have 3 kids, an 11-year-old, a 5-year-old, a 2-year-old, and as we get older, I realize my children steal like all of my memory and most of my even faculty capability. It's like your brain just goes, and so we all know that. Most of the people that are they have kids, they know the deal, and so I would just encourage you, if you don't understand and you're not sure, to ask. It's okay.
I'm a terrible public speaker, but I am someone who reads every research paper that I can about CF. And I started from scratch, didn't understand it, read over and over and over. And one of the things that I've learned is that there are these amazing researchers all over the world studying CF. And not only do they produce these papers, but if you write to them, most of them will answer. And so I've asked many questions that somebody might think is stupid, but they don't. They're excited that you're interested in their questions, and they want to explain their research. And I find research so satisfying because I see what's coming. I know how good it's going to get because it's already in the pipeline. It's coming. And anyway, that's what I wanted to say about asking those questions.
I totally agree with what Sandy said, and I understand that in the beginning, there's this huge learning curve, and it can be really overwhelming. It's like you're learning the infection control, you're learning how, just the personality of your baby, and so many different things. But like Sandy said, for me, the more I learned, and it's just the process of kind of putting in that time, reading and asking those questions, the more hope I had. And I can honestly say that in CF right now, it's very hopeful. And so taking that time to really try to understand that science and asking those questions in clinic can be very rewarding. And for me, my background was in chemistry, so following along with Kaleido while it was still in development was like the most exciting thing in the world for me, right? And then just being aware and feeling a little bit more confident and hopeful about where we were going has been a huge just coping kind of technique for me. It's really hard living and dealing with CF on a day-to-day basis, so if you can see that hopeful future out there, for me, that's what has kind of addicted me to the science. It's just that I want that hope. I want more. It's good news that we have to learn about right now. So that's the good thing.
That's so satisfying.
So any other comments about, or does anyone have a question about medical terminology?
I have a question when you talk about research, because I'm pretty hesitant and leery about researching. Going on the CF website, but I don't really like to do too much dabbling, like research on the internet. So, like Sandy, you said you love to research. Where do you typically go, or you know what I mean? What would you recommend?
I love there's this website, Google Scholar. So these days I pretty much just look at research papers. I don't read a lot of blogs or personal accounts because it can get sticky. But just scholar.google.com pulls up any paper, and I'm to the point where you can click on a little button that says rank it by date, so I can look at just the newest papers for CF. And it's, oh my gosh, the thousands of medications that are being tested right now in labs, and then the hundreds that are being tested in people right now. It's just phenomenal, and the results, I can't tell you, it is just amazing what's coming.
I have one other thing. On the medical side, like from a healthcare provider, sometimes we get going in our day and we're doing the same thing over and over, and we get talking the same thing over and over, and we don't realize that people aren't understanding what we're saying because we say it all the time, every day, 5 days a week. And so I love it when people say, wait a second, slow down. Yeah, what is Pseudomonas? So, how do you spell that?
I just had one more quick thing about resources or where to go for information. I mean, the CF Foundation's website does have a lot. I mean, that's a trusted site that you can go to, but it can be, again, overwhelming with where do I even start with this? I mean, you can go look at the drug development pipeline is a good place for things that are getting maybe closer to becoming a market reality. And then a couple of times a year, like next week when we go to the March on the Hill event, there is also the Volunteer Leadership Conference, which brings together volunteers for the foundation from all over the nation. And they will do kind of a condensed scientific update at this conference that will give you the latest and greatest. And that will be in a webcast on the foundation site probably just a few days, I'm guessing, or maybe even immediately, I don't know, after the conference takes place. And then in the fall, they have the big scientific conference, the North American Cystic Fibrosis Conference, that also has more in-depth accounts of kind of, I mean, it's a multi-day conference and there's a lot of science there, but they do these big plenary sessions that are kind of the big breakdowns of like what's going on in the field of CF, that all 4,000 plus medical professionals that attend the conference will sit in these sessions. And so those are the ones that I think, you know, if you have 2 hours to put into CF research, you know, this month or this week, getting a hold of some of those condensed versions from the the 2 conferences that go on every year can be a great place to get the latest and greatest.
And know that families are welcome. I mean, parents are welcome to come to some of those events. So even though it does involve travel this year, it'll be in Phoenix. So we're excited for warmth. But I mean, as parents, you know, you can attend. They have different options and prices, and there's some tracks that you can go if you're part of an advisory panel, things like that. So if you're ever interested in things going on where you'd like to get more involved, but a lot of like the plenary and some of those things are on the foundation website, so you can look and see. You can watch the event as a webcast. That's in the library. As far as some of the jargon too, you know, the downside of Epic is some of, you know, our system is all the computer stuff. A good part of it is the MyChart option, where you can have access. That's only 12 to 17. We don't have access yet. But, you know, if you have questions about like culture results, you know, stuff we're saying on the phone, and you do have MyChart, I'm happy to send that. And so sometimes having it in writing then helps you go to the CF Foundation website, maybe learn more about that bacteria, or, you know, so never feel like I said, if you feel like, how do you spell that, or what does that mean? I know we're more than happy, and sometimes we just don't, again, realize, like, oh yeah, I guess not everyone deals with Pseudomonas every single day, so. All right, any more questions about kind of that train? So we'll move on to exercise, and I know that that's been a big topic for all the people on the panel, just in their own personal life, dealing with CF, and so we just want to kind of open that up. What does exercise mean to you, Lloyd? Yeah.
For me, honestly, it's probably one of the things that's helped me live as long as I have. My mom, I was telling somebody out there, I remember I was born in 75. Back then, they didn't know a whole lot about CF. My mom has told me the instructions, like, they would tell her, be careful, don't feed him anything that's high fat, so don't eat pizza, don't eat, he's not going to be able to digest any of it, and she did anyway. She's like, I'm not sure I'm going to get calories in the kid, right? So she just feed me whatever I eat, and they actually told her, you got to be really careful about exercise, because, you know, not sure how much to take, and it's like, seems to me we should work his lungs. So she actually, I remember, she was training to be a firefighter, and so she'd make me run behind her, and I'd whine the entire way, you're trying to kill me! Like, shut up and just run. So, but from really early on, it was a part of life, and I think even looking at, like, right, we have a 2-year-old, a 5-year-old, 11-year-old, none of them have CF. Our oldest daughter is biological, and the younger 2 are adopted, but if I would want, it is anyway, but I would want a part of their lives to be very much activity-oriented with a purpose, if that makes sense, knowing they may not know why we take them to the playground every other day and we make them go and go and go and go, but we know why we do that. I think it's as important as the machines I do as the exercise I do. It makes me, honestly, as I get older, it makes me feel like I'm beating CF when I can exercise. It's something psychological that helps me more than just physical, if that makes sense. So it's a huge part of the care, as critical as almost anything else I think that you can do as parents, or that we do when we're old enough to live with it ourselves. So
I'll just say that Laura was talking about the 504 plans. My son goes to school 2 hours late every single day, and what that does is that gives us time to do his therapy and then go to the pool or go for a walk or whatever. Let him get extra exercise in during the day that we normally wouldn't have time to if he went to school full time. And I don't think Laura mentioned this, but there is, and I haven't applied for it yet, but apparently there's also a $500 a year grant that you can get that can help fund exercise programs, swimming lessons, horseback riding lessons, you name it, camps. So that's something I would definitely be asking about when you go to clinic.
I just wanted to, I'm really excited about the exercise. The exercise is getting talked about more, and at the big medical conference this last year, the NACFC, they're finally starting to come up with some data and have some studies to show that, what makes sense, that exercise is good for everyone, including those with cystic fibrosis. And for those with CF, probably even more important. They have data showing that, even for transplant patients, you'd think, look, lung disease is a good excuse not to exercise, right? PE, whatever. But it's exactly just the opposite. Even patients that have very low lung function that are on the transplant list benefit from having an exercise bike in their room. At the conference, they had a big session where it was they discussed a topic, they debated a topic, and the topic was, can exercise be an acceptable replacement for airway clearance? So like for the vest, for the acapella. And different scientists spoke and gave their side of the argument, and then the crowd clapped, to vote for one way or the other, and it was actually pretty evenly split. And I think that what they kind of concluded at the end of it was that right now with the data that they have, exercise should be seen more like a prescription for those with cystic fibrosis. It's not, it's an adjunctive thing. And like Lloyd said, there are so many extra benefits, mental benefits, sleep benefits, depression benefits. It's a full body. It improves so many different things that it's a tool that we have right now that we have data that is more powerful sometimes than certain pharmaceuticals that we have. So why not take that and utilize it the best that we can?
One thing to point out with that too is that some of the studies are supporting that the more vigorous is actually the better. That shorter, more vigorous seems to, from the lung clearance standpoint, is actually a little more effective. So going out for a jog would be better for the lung clearance side than just a real casual walk. So this idea of holding back because they have CF, it's actually push yourself a little bit. But one of the questions that's been brought up, well then how hard do we push? And where is that line? And especially as some of our patients are getting older and have more disease, how much do you push it? And I think that, there's, when they're kids, I think all the doctors would agree is we don't want you out there, in PE, if they're feeling short of breath or if they're not feeling good, they should probably rest. We certainly don't want to, have anyone get hurt in the process. But just like with all of us, start gradual and work up. And, CFers have been known to go out. We have the Boomer Esiason has a whole team of marathoners, and some have CF and some don't. Some of them are triathlons, and it's really exciting. So I think the bottom line is don't be scared of encouraging your kids to do it. Start slow, but get better just like all of us. One question I have for the panel and then any other people is, what are either you or your family, what are some of the activities that you're finding that is good for your family?
Well, I know for us, we had a little mini trampoline in our living room from the time that Grady was, less than a year old. It had a little handle on it, and he would hold onto that handle and just go to town. So for some of the littler kids, especially being indoors a lot, that was a great, jumping has been shown to be a really good activity for them. We also have a bouncy castle place in Coeur d'Alene that literally, or Sky High Sports, I know here in Spokane, there are a couple of different places that are bouncy. Those are fun for the littlest kids. And then I guess guess once you get into team sports or school activities age, then you kind of got to maybe go with you got a soccer player on your hands, put them in soccer. Let them pick whatever they want to do, I would say, is the best activity for your family.
Yeah, I was thinking, one of the things I appreciate about Lloyd's mom is she didn't hold him back from any activities. He did football. He was third string because he was so tiny in junior high. But he wanted to do it, and she was like, go for it. Just whatever they seem interested in, let them go for it, because if they take interest in a sport, then they have this vested interest in it, and they get excited about it, and they want to do it and push themselves. And for us, we go to the gym together, and he started lifting weights and running. I think for him, running clears his airways a lot of times better than, like, he'll do some machines and then he'll go out and run and clear even more out. And so it's very beneficial for him. And we got the $500 thing. It's fantastic. Talk to Kendra about that.
We go swimming and we go on walks and runs and go to the playground. But one thing I'll say about my kid, and all our kids are different, but he's not the most coordinated kid, and group sports aren't really that interesting to him. He doesn't necessarily pay attention for that long. So having somebody work with him one-on-one, it's often me, but it's really helped to have a swim teacher coaching him just one-on-one. That has helped immensely. It just motivates him. He wants to work with a person, not a team. It's overwhelming, but just one person at a time. That's person by person. It varies.
As Abby said, sorry, I played hockey, and pretty much everything I ever did, I was the littlest, the smallest, the slowest. But it didn't matter. My mom actually realized I was winning if I was actually going to practice. Now, I didn't realize that, right? But that's the whole goal. And as Abby said, I had a vested interest, so I just keep trying and trying. If I look back, though, the things that have best suited me, running has probably been better than anything else. I can't run nearly as much as I used to. But anything, I'm far better off if I can do it outside, where I can clear whatever I cough, right, when I cough it, if that makes sense. Yeah, so just spit and, even golf. I know, it's a blessing that I was born a guy, because you can be a spitter and a guy, and it's not so bad, and I don't know. That's right. My kids, all of them try to spit, like that. But, if I swim and stuff, I'll cough, but I really miss the fact that I can clear whatever I'm coughing right then. It's still helpful, don't get me wrong. So, kind of to Kendra's point, if I had kids, and I remember being young, I pushed myself as hard as I could possibly go to exercise. If I was sick, we tried to figure out how to throttle back. I remember times where my mom would not let me